We have reached the final chapter in our book, Alzheimer's Disease and Other Dementias. In this chapter, we will learn the different things that happen to brains as they age. Dementia is a disease. It's not a neurological event like aphasia or a stroke. A stroke is something that happens and it's done. Dementia is a progressive disease, which means it is persistent and function and intellectual functioning decrease over time. The primary characteristic of dementia is deterioration of memory. In aphasia, one just has difficulty with language, not overall cognitive functioning. The memory deficits have to occur in more than 6 months and have to impact cognitive or intellectual functioning. Alzheimer's is the most common type of dementia. I think a lot of people just assume that Alzheimer's is dementia, but we will learn all of the different types today. Dementia is the most common cause of language impairment in older adults above age 65. It's more common than a stroke and aphasia and affects all areas of cognition, like I said earlier. Whereas aphasia is just language, dementia affects the entire brain. The role of a speech-language pathologist is to look at the assessment of all areas of language, which includes semantics, pragmatics, morphology, syntax, and memory. What about aphasia and Alzheimer's? They can occur simultaneously, but they're very different. Aphasia is loss of language, whereas Alzheimer's may have some language issues over time, but not as severe, like I said earlier. With aphasia, one can improve with therapy. It's static. Once the injury is over, it doesn't get worse, whereas in Alzheimer's, it's progressive, it gets worse. In aphasia, there is neuroplasticity, so there are parts of the brain that haven't been damaged that can help with the recovery. Whereas, like we've learned, Alzheimer's is all over the brain, thus we don't have that neuroplasticity. Take a second now to stop the PowerPoint video and look at Table 15-4 on page 613 for a comparison of the two. Dementia is classified by the location where the damage occurs first. We have cortical lesions and then we have subcortical lesions. The cortical ones are typically in the hippocampus and in the neocortical association areas. The hippocampus is the center for memory. This is also one of the infarcts seen in someone with traumatic brain injury, that the hippocampus also gets damaged. This is where the cortical lesions are in the hippocampus. We see this in Alzheimer's and Pick's disease. A person with a cortical lesion is pretty much indifferent about their deficits. They don't really realize that they even have deficits. The second is subcortical, which occurs in the basal ganglia, rostral brainstem, and thalamus. The difference here is there is a motor involvement right away. Typically in cortical lesions like Alzheimer's or Pick's disease, there's not a physical or motor issue problem. But you will see in someone who starts having some memory issues, and if they have some motor issues also, then it's probably a subcortical lesion, which could easily be Parkinson's, Huntington's, or a type of dysarthria. A person with a subcortical lesion is aware and concerned about their deficits, probably because it's much more noticeable because you can't move around as much as possible, which can result in depression, which can make the dementia even worse. Lastly, someone could have a mixture of these two, and it would be called mixed dementia. What is the neuropathology? Dementia cannot be diagnosed definitively until death. Like so many of our language disorders, there's no definitive diagnosis. In aphasia, we can neurologically see a stroke. In Down syndrome, we can do genetic testing. But again, with dementia, it's all about the symptoms that we look at and make a decision based on these symptoms. But once someone has died, brain imagery can be completed and the brain looks like a tangled hair is what they see. All the neurons and fibers are all tangled up together in mats. There's also an increased number of plaques in the area of degeneration. There will also be a lot of different little lesions. Remember, little spots of brain damage in different parts of the brain. A person usually loses about 10% of the weight in the frontal and temporal areas. This is why executive functioning, decision making, personality, and language are all impacted. So, what are some of the risk factors for dementia? First, we often see a family history of Alzheimer's, Down syndrome, or Parkinson's disease. Also, we see a late onset of depression with individuals who have dementia. Another risk factor is a head injury, which makes sense because of the previous brain damage. Then a person with hypothyroidism, where the body doesn't produce enough of the thyroid enzyme, seems to have a risk factor to it also. Lastly, a person with a mother that was older than 40 when they were born can be more at risk. Dementia is categorized as reversible or irreversible. The reversible types of dementia can be repaired. So if a person goes into depression, they tend to withdraw. They don't communicate as well. They don't attend to what someone's saying. They start demonstrating those behaviors. Once you get the depression managed, then those symptoms go away. The same thing with drug toxicity. There's certain drugs that one can take that cause these behaviors. We had a patient come here to our clinic, and one of the professors, Dr. Liu, who's now at the University of Texas San Antonio Medical Center, had a patient, and she noticed the patient's walking and their different motor behaviors. But nothing else matched up to a diagnosis of Parkinson's, which had already been given to her. So Dr. Liu asked the patient about the drugs that she takes. Her understanding and knowledge of the drugs was very important because she realized that the mixture of the drugs was causing these symptoms which looked like Parkinson's. Once the drug issue was straightened out, the person was no longer showing these issues that looked like Parkinson's. Then, of course, the cardiopulmonary. Remember, the cardio is the heart and the pulmonary is the lung. If a person has trouble with heart pumping oxygen, then that person is going to have damage in the brain. For someone who has developed AIDS, they may develop dementia in the later stages because it does affect them overall in their damage to the brain. The loss of memory and skills due to these factors can be reversed as these causes are treated. Reversible dementias are often not reported because these can occur also in someone who is younger. The person might think about dementia as having to do with someone who is older and not someone that young. And this even is seen by the doctors. They don't think about it as quickly. So for irreversible dementias, the most common cause is Alzheimer's. Multi-infarction diseases are the second most common cause and are diseases that result in many focal lesions causing widespread damage in cortical functioning. Parkinson's and AIDS can also cause dementia. Irreversible dementias are the category in which we will spend most of our time the rest of this chapter. Of the irreversible, the diagnosis involves detection of sustained deterioration of memory for at least 6 months and disturbance in at least 3 of these areas. First is understanding orientation to time and place. Orientation is figuring out where one is in the general or specific time. Second is difficulty with judgment or problem solving. They can't make a good decision and can't follow through on tasks. We will start seeing that they do not participate in things in the community. They might have been a churchgoer, but then now they've stopped going to church. They don't stay with their groups or social groups. They might not do the same thing in the home that they've always done. They might quit cleaning the house, which, hey, most of us would like to do anyways, though, right? But any hobbies that they have, they might be needle pointers or painters or readers, and they quit doing all of that. Then the personal care, they just kind of quit taking care of themselves. You have to see at least 3 of these problems along with the memory being gone for 6 months. It is a gradual onset, so it comes on slowly, but it keeps getting worse. It's not like one day a person says, "My dad has dementia." It's something we see coming on until it's such a degree that it's really interfering with the person's life. With Alzheimer's disease, it is the most common type of dementia and it's the 4th leading cause of death. It's a very significant and difficult disease. Cognitive skills go away over time. How fast it occurs depends on the individual. Some people go for years with very gradual losses. It is often a great expense on the family. It's very, very hard on those that still have good memory to know that they're not recognized and remembered by those that they love. But a person who has a good heart, a healthy person, can go on for a long time with Alzheimer's. But then there can also be someone who develops Alzheimer's and doesn't survive for 5 years, so it varies. I hear once that Sandra Day O'Connor, who was a Supreme Court justice, her husband had dementia, and she ended up putting him in a memory care facility. She talked about how difficult it was since when she would go visit him, all he wanted to talk was about his new girlfriend and how he was going to marry his new girlfriend. Of course, he didn't even know that she was his wife, so it's pretty hard. So what is Alzheimer's? It's characterized by language, memory, reasoning, and judgment deficits. Because it is a irreversible dementia, we see progression of symptoms over time. Then there are personality changes within that individual. What's the criteria for Alzheimer's? Memory and cognitive deficits, impacts on social and occupational functioning. Again, basically what we have already discussed, onset is progressive and not due to any other condition or disorder that we have previously discussed. There are 7 stages of Alzheimer's. Look at table, let's see, that's probably not 115-8. I don't know if that sounds right, but anyways, go to page 617, which discusses each stage. The stages go from no cognitive impairment to very severe cognitive decline. Stop the PowerPoint video now to look at these. I'm going to highlight some of the characteristics seen in the next 2 slides. At the middle moderate stage, which can go on anywhere from 2 to 10 years, we see social withdrawal and flat affect. Remember we discussed flat affect in people with right hemisphere disorder. We will also see difficulty naming and their vocabulary skills will begin to decrease. They start having anomia and word retrieval issues. They don't notice their errors, so they don't correct themselves. We will also see the semantic paraphasia begin. They'll start using incorrect grammar. Again, they're not aware of it. They also don't make good decisions and they are not very tactful. They can be insulting actually, which can be very hard to take. They don't know where they are and when it is. Then their reading and auditory comprehension can also be impaired. Then in the later stages, the naming or the anomia becomes significant. They will have a lot of jargon and repetition. The jargon, remember, sounds like babbling with words and they'll just repeat things. There again, we will see the paraphasias and neologisms you see in Wernicke's. They can't remember how to do something. They have difficulty with procedural memory. I heard about a patient at our clinic who the student clinician had to make a picture schedule for the client on how to brush her teeth because the procedure memory was gone. Just like the middle and moderate stages, disorientation to place and time occurs, but we see disorientation to people also at these later stages. Lastly, we see the person is dependent for all activities of daily living, like dressing, feeding, and personal hygiene. Hearing loss may account for some of the problem behaviors reported with Alzheimer's. Evidence shows that this population is under-referred for testing often. Now it is time to watch 3 videos. The first one is pretty difficult to watch. It's a man who lives at home with his son. His son did a video of him, and you see what the man does. He does this all day long, every day. Then the second one is a news broadcast where they had someone go in and simulate what it's like to have dementia. Then the last one I think you'll love. It's a man that's in a nursing home facility and how the music helped him to bring out his personality and helped him with his retrieval and words and communication. Have fun watching these. Now we're going to discuss some of the other irreversible types of dementia. In Pick's disease, it does look a lot like Alzheimer's, but it's different where the damage begins. The person with Pick's disease starts losing their brain mass, the size of their brain, very early on. You'll start seeing some social behaviors that are really not appropriate. They have a lot of disinhibition. A lot of times we will see excessive eating, and with that comes weight gain. Eventually, their language becomes all echolalia, where they just repeat what they've heard. They'll repeat just what someone said, or they'll repeat back what they've heard a while ago. So it's just they'll say things that have no meaning, and they have problems with their language form. Of course, that's morphology, syntax, and speech sound productions. Um, so even though that content, the semantics and vocabulary may still be okay. But again, they will have difficulty retrieving these words. They will progressively end with being mute. Now we're going to discuss multi-infarction infarction disease. We will see this disease in about 20% of people who have been diagnosed with senile dementia. Someone who has had problems with hypertension or their blood pressure, they call this vascular dementia because the person has a history of small strokes. What they see on the MRIs is all these spots of damage. We also see a lot of difficulty with emotional control and impulse control. So they will have a lot of emotional liability, which may mean that they'll cry a lot or they're going to laugh a lot. We also see changes in their personality. They also lose memory and then it comes back. So you have some independence, but gradually they lose their intellectual functioning. Depending on the site of lesions determines their symptoms. Everybody may have a different pattern of strokes, of site of strokes, so there may be very different patterns of behavior. Next, we're going to discuss the subcortical dementias, Parkinson's and Huntington's. I think most of us at least have heard of Parkinson's. Parkinson's is a progressive disease. It starts with those motor disturbances, which is why it's subcortical. It has those motor disturbances. Up to 10 to 20% of people with Parkinson's develop what we call full-blown dementia. A lot of times they never develop this dementia though. They can also have what is called a resting tremor. Their hands might shake even when they're not doing anything, or their head shakes. They will also have gait disturbances, and that is where a person's feet kind of just shuffles along and drags along on the ground. Also, with the motor control issues comes difficulty controlling the rate of speech. It can be slow or fast or both ways. They also have difficulty with focal intensity. A lot of work the speech pathologists do with patients with Parkinson's is working on their voice. Then again, the pitch and articulation because of the motor control. There are a lot of programs for Parkinson's patients, with one of the most known is called the Parkinson's Voice Project. Look that up if you're interested. The language issues in Parkinson's, you'll see again, is the word finding, which is in all of the dementias. Some issues with cognitive abilities and memory and confusion will be a problem. People with Parkinson's take a lot of drugs to help manage the tremors, so sometimes the confusion can be related to the drugs. We have to be really cautious of any patient who is taking drugs and how the mixture of medications can impact them. With this feeling of losing your language and your cognitive and your motor skills, of course, depression can really impact them. Huntington's disease is also known as Huntington's chorea. Chorea is like these jerky, involuntary movements, whereas Parkinson's is a tremor. What you see in Huntington's is more jerking, and it's very irregular and erratic. Huntington's is genetic and passed down in the family. Again, there are the motor issues that start up early because it's subcortical. There is also limb and facial muscles involved. The person loses orientation. They also slow down their talking with overall less verbal output. Once diagnosed, these patients can survive for about 20 or 10 to 20 years. Let's now discuss how the SLP can assist in managing the communication with a person experiencing dementia. How does the dementia affect the patient's communication? What we see first are people just leaving out a word. They're having trouble retrieving those words also. We'll have that issue where we sometimes can't remember a word, can't pull it out. It's when it becomes more consistent, more noticeable by others. There's deficits in their conversations, their understanding of humor also. We start seeing some little differences here and there. In the middle stages, we really see a lot of word retrieval issues, that anomia. They'll repeat and they'll also have that echolalia. They'll repeat what you say, or they might just repeat phrases. If you're having a conversation, they'll just forget what you're talking about as soon as you say it. Lastly, they will not greet someone when they come in or when they see someone. Some of the later effects are that they might begin having some speech sound errors. The ability to retrieve words, the anomia becomes very significant, and they start making up words or paraphrases. You'll start seeing them use jargon. Jargon is babbling again, and they can't sequence their thoughts. They don't seem to know where they are. One of the most painful things for the family members is the insensitivity to others. They might just say very ugly or mean things to other people. It can be very difficult for everyone in the family. Eventually, in these later stages, the person may quit talking altogether or just repeat. So stop the PowerPoint video now and look at table 15-3 on page 611 to see these list of full effects. And again, these are going to be very similar to the early and late stages that we talked about with Alzheimer's, but just a little bit different also. So with narratives and discourse in dementia, we see a reduced ability to change topics and maintain a topic. And then, of course, difficulty contributing to topics that people are discussing. So that makes sense, right? We have all this anomia, we're disoriented to time and place, so in people, so it just makes sense. And then over time, their ability to repair conversation decreases also. So now to the management. Remember, there's no cure for dementia. That's the sad part, no cure. but the SOP will help family and patients manage the disease. With the individual, especially in the early stages, the SOP will help the patient figure out ways to help them cope with with what they're doing. So teach them to keep a list, keep a calendar, write things down. We'll discuss some of the different strategies. The SLP's role in working with patients with dementia is varied. First, we complete language and cognitive testing to assist with the diagnosis of the disease. We will often do baseline testing, and then with subsequent follow-up testing sessions, we can document decrease in skills. We also provide the individual with compensatory strategies to facilitate optimal function and educate the family members in ways to adapt the environment to optimize function. We will talk more about those on the next slide. With the family members, a couple of things the SLP has to think about. First is the environment. Do they have a safe environment? When you watch the video of the man living at home with his dad, you saw that there are little things that you wouldn't think of about that are not safe, like kitty litter. Another thing is that the family has to make sure that the doors are locked. I've heard that it's recommended to put a black rug in the front of the door. So if they open the door, that black rug looks like a hole, so they won't step onto that rug and go outside. I'm pretty sure many of you have seen the silver alerts on the highways when it gives a description of the car when someone in the earlier stages of dementia has gone driving and the family can't find them. That's another aspect that the family has to consider. When do you take the keys away? So when does the family make sure someone is with them also 24 hours a day? Those are the hard decisions that the family has to make along the way. Lastly, for a lot of people, AAC devices can be appropriate. So we'll assess and work with AAC devices with really a lot of these patients. Compensatory and environmental interventions that the SLP helps with helps the patient be more functional with what skills they do have. First, the SLP helps with memory strategies such as having a calendar, daily schedules, notes, checklists, and a medication schedule. My dad has difficulty with remembering his medications, so the pharmacy organizes his medications into sealed packets that are labeled for each day, and then he takes medications in the morning, afternoon, and night, so it's labeled AM, midday, and PM. Things like that, the SLP or the nurses, if they're in there, things like that can help identify strategies to implement. The SLP will also help the family set up and maintain a predictable routine. The patient needs to know what is going to happen and when, and really have much of the same routine every day helps them be more functional and more independent. The SLP will assist the patient and family in knowing when the patient should discontinue activities that present a safety risk, like we just discussed, driving or cooking. Lastly, we will help the individual develop a plan for assistance with money management and living arrangements if needed. Depending on where you work, you might have a social worker that helps you with some of these issues, but then I know in some settings it is the SLP who would be doing a lot of these things. So congratulations, we are now finished with learning about language disorders. I really hope you've enjoyed this class. I know I have. It's been really interesting with the online. I appreciate your feedback on the spot evaluation so I can incorporate your ideas for the next set of students. I know I have a list of things I for sure want to do next time, but I really am really appreciate you guys' feedback. Thanks and good luck with your next classes, or a huge congratulations to those of you that are graduating this semester.